tes 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 1 2 3 tes 1 2 3 tes tes 1 2 3 tes
Sekarang gini itu di mana?
Pindah lagi.
Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Namo Buddhaya, Salam Kebajikan. Good morning and welcome to today's international guest lecture with the topic The Strategy for Improving Maternal Health in Japan. My name is Cynthia Pratnya and I am honored to serve as your Master of Ceremony for this event. Before we begin, allow me to extend a warm welcome to our respected guests. Good morning to the Vice Dean of the Faculty of Medicine, Udayana University, the coordinators of study programs of the Faculty of Medicine, Udayana University, our distinguished speaker, Professor Eiko Yamamoto, MD, Ph.D., and all esteemed guests who cannot be mentioned one by one. To commence our event, let us start with a prayer to seek blessings for a smooth and fruitful session. Before we begin the prayer, may I kindly ask all attendees to please stand. Praying start. The prayer may be concluded. Thank you, and please be seated. Next, we will hear a welcoming speech from the Vice Dean of the Faculty of Medicine, Udayana University, who will also officially open today's session. Please welcome Professor Dr. Imade Adi Wirawan, MPH, PhD, to the stage.
Terima kasih. Awali dengan mengakhiri Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to welcome special guest Professor Yamamoto, Nagoya University. Thank you for coming to the to be with us to give your expertise with our students and also faculty. Ibu-ibu dari Kementerian Kesehatan, terima kasih sudah berkenan hadir. Thank you for introducing to our institution. We are very grateful and we are very excited to listen to your presentation today. Bapak Ibu para peserta yang berbahagia yang berkenan hadir untuk mengikuti seminar pada pagi hari ini. So the topic that you propose is very relevant to our situation in Indonesia, and it's struggling with the maternal and child health awareness, with the maternal mortality ratio, for instance, high mortality rate is still a lot of challenges in Indonesia, and we hope that your insights on what have been done in Japan will expand our horizons, will expand our insights, so probably we can learn some of the best practices that you have. And thank you for the organizing committee from Dr. Ayu, from School of Public Health, Graduate School of Public Health, Anom as a moderator today, and also the organizing committee at the back. Thank you very much for making it happen. And once again, welcome and thank you for coming. And we really hope that today will be a fruitful session for discussion, also for sharing your expertise. So on behalf of the Faculty of Medicine, I officially open this guest lecture by Professor Yamamoto. Thank you. Untuk para pesanti Om, Santi Om, Assalamualaikum, Shalom, Namo Buddhaya, Salam Sejahtera. Terima kasih.
Thank you, Prof. Adi. Allow me to introduce our moderator for today's session, Ngakan Putu Anom Harjana, SKM MA. He is a lecturer at the Public Health Program, Faculty of Medicine, Udayana University. His expertise spans areas of sexual and reproductive health, health advocacy, and pandemic preparedness. Some highlights of his academic and professional journey include a master's degree from Mahidol University, Thailand, publications such as Health Information Seeking Behavior and Sexual Risk-Taking among MSM in Bali, Indonesia, numerous community and social activities, including membership and the Indonesian Student Advocation in Thailand. So now please welcome Ngakan Putu Anom Harjana, SKM MA.
Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom nama budaya, salam sejahtera untuk kita semua. Selamat pagi yang terhormat Prof. Adi, Dr. Ayu, Bapak Ibu semuanya. Welcome Professor Eiko Yamamoto. Now we would like to invite you, and today we have a special guest from Nagoya University with the topic of the guest lecture, the strategy for the improving maternal health in Japan. And maybe we will directly continue to the session. We would like to invite to you Prof. Yamamoto Sensei to come to the stage. Before we start, we would like to introduce our speaker today. We have Professor Eiko Yamamoto, or we can call you Yamamoto Sensei. Yeah, she's from the Department of Healthcare Administration at Nagoya University. And yeah, you can scroll down a little bit. Yeah, this is the education background of Professor Yamamoto, and maybe you can scroll down about the reasons. Professor Yamamoto has already done a lot of research in the topic of the maternal health, and today Professor Yamamoto will share the research finding related with the maternal health situations in Japan. And how are you, Professor?
Good morning. Selamat pagi. Thank you very much for second this opportunity for me. I'm very glad to see all of you and visit Bali, Indonesia. So I'm very fine today.
Okay. Now, are you ready to present your finding? Okay.
Yes.
Okay, you can start.
Thank you very much. Thank you very much. Can I start?
Yes.
So I like to talk about how Japanese maternal health and child health is improving Please move. Yes. So this is. Thank you. This is my introduction, my background. So originally I am an obstetrician and gynecological doctor. So I have been working as a clinician for many years. But I started working for Vietnam about gynecological diseases. So that was my first step to study in Asian countries. So I moved to Young Leaders the Department of Healthcare Administration. This is one of the departments of social medicine. So still I'm working as a clinical doctor, only about like 10% or 5%. But most my job is working for education and also doing research. So this is my picture of that I performed the operation for cancer patients, and the middle is so when I visited the local public clinic with my student, including and I visited the Ministry of Health and saw the Minister of Health on Monday. So next please. One of my specialties is gynecological cancer. So tomorrow I will make a presentation about trophoblastic disease management. I am invited to. Yes. So I am a specialist of trophoblastic diseases. So this disease is occurred from placental cell. So from pregnancy, the colocarcinoma is actual cancer. So in Japan, 50 or 60 years ago, this was a major cancer, and many women died. So, but we found that the percentage from the pregnancy to colocarcinoma is very low, but having high for more is a risk factor. This is an abnormal pregnancy. So if we follow all high for more patients, we can prevent colocarcinoma. So our university started the registration system of high for more. Now it expanded to all places in Japan. So now the colocarcinoma patient mortality is very low, but still we have some death cases. So I'm still working for this disease. This is one of my specialties. So now I'd like to talk about maternal mortality ratio. And then, so this is the graph. I took this data from WHO 2020. So here I put many countries in the world, and also I put the Japanese maternal mortality ratio into 1955, 1975, 1995, and 1991. So you can see the Japanese MMR decreased. And here is Indonesia. So you can see the Indonesian MMR is the same as the Japanese one in 1955. Where is the computer? Okay. Thank you. So you can see here that so in 1899 in Japan, MMR was 400. It's very high and decreased to now 3.5. So why MMR has been decreasing so much? So there are some reasons and some strategies. So this law regulation is very big region. So regulation of midwife, so traditional birth attendant, so that should be shifted to midwife with licensed. And also the law of the community nurse. So law related to nurses or midwife also established, and state examination for midwife introduced in 1951. So this law regulation is one of the reasons. So this graph shows the trend of birth and death in Japan. So blue shows birth, red shows death. So now the number of births is decreasing so much. Now 0.7 million per year, and but the death is increasing. So it means the Japanese population is shrinking a lot. Next. So this is a actual picture of Japanese old era. So they are traditional birth attendants. We had Japanese like old lady in the community or the villages. They helped childbirth at home. This is also a TV drama in Japan. We can see traditional birth attendants. So as I explained, the first regulation of midwife license is decided. So this is showing the how the educational system of midwife and public health nurses. So after high school, here, so 3 years education is necessary for being a nurse. And university provide 4 years education. We also have nurse high school. So this is 5 years, including like high school education. So first examination nurse. So in Japan, midwife is higher than nurses. So after being nurses, they can be midwives. So after being nurses, so they have 1 year training course or 2-year master program at the university. Then they can have an examination. Then can be a midwife or public health nurse. So maybe I think that these educational systems are different in each country, but I think most countries in Southeast Asia, midwife, the education for midwife is shorter than nurses. But in Japan, midwife have already have knowledge and experience as nurses. So this is big difference. So next. So other than law regulation about certificate of nurses or education for nurses and midwives, so the place and the responsibility for childbirth is decided in Japan. So only doctors and midwives can assist, not nurses. So nurses cannot perform examination for delivery or pregnant women. It's prohibited because this is a job of doctors or midwives. So nurses do not have training for delivery or antenatal care. So only midwives can assist at normal delivery. So midwives can assist only normal delivery, or midwives can open their own center. So if the birthplace is hospitals and clinic, so doctors and midwives are responsible for assisting the delivery. So midwife can assist normal delivery at midwifery center, or if patient want home delivery. But without midwife or doctors, so childbirth cannot be assisted by other persons. So this graph shows the facility. So where childbirths are occurred in Japan. So in 1950, so mostly part shows others like home. Others means homes. So most childbirths were at home, but gradually the proportion of home delivery decreased, and now mostly like you can see, red means clinic and hospital is blue. So after 1960 or 1970, so I was born actually in this year. So I was born at the hospital. So at that time, most childbirths were at hospitals or clinic by doctors and midwives. But when my parents were born, or my former professor was born, they were at home. So this is a paper of the birth certification of Japan. So left part should be filled by a parent, and right part should be filled by healthcare workers, doctors or midwives. So this is the right part. So the name of the child, and the sex, and date and time of birth, a place of birth. So place should be selected from hospital, clinic, midwifery center, home, and others. So that's why I could show the data of the previous page. Because of this birth certificate, we collect the data. The government have accumulated the data. And the baby's birth weight and height, or single or multiple, or the mother's name, and destination of week, and then who can write this paper is doctor or midwife mostly. And we have to sign on that page. So to reduce maternal mortality ratio and infant mortality ratio like this, it's difficult to see the yellow one. So not only the law regulation, but also like a health nurse system, a public health nurse system, or handbook for mother and child health. This also made the law, and Ministry of Health was established here. Or universal coverage was achieved in Japan. And not only law related to mother and child health, but also that clean water is important. So sewage coverage and sewage system are developed. So the coverage is like 86% around 1980. So now also the water supply is almost 100%. So in Japan we can drink tap water because of the water system is good enough. So public health center were made before the Ministry of Health established. So why the public health established is because mainly the infectious disease and maternal and child health. So she is public health nurse. So she visited homes in the communities and provide lectures or guidance about nutrition or mother and child health. So this is the starting of a public health center in Japan. So I explained the universal health coverage. So now all Japanese people must have health insurance. So why health insurance coverage is important? Universal health coverage is important. It means like easy access. So access or affordable services are important. So because we achieved health universal coverage, so the government produced doctors, established hospitals, clinics to provide health service equally, so everywhere to every person. So this graph shows the number of university, and so red line shows the enrollment limit. So government control the number of medical students. So because it can be a medical doctor. So universal coverage achieved in 1965. So then after that, to produce more doctors, the government decided that at least one medical university in one province. So now we have 82 universities in all over Japan. We have 47 provinces. So in my province, we have 4 universities. So we think number of doctors may enough in Japan, but the government don't think it's not enough because non-distribution. So in the urban area, we have many doctors, maybe the same in every country or every region, but we need more doctors in rural area or for some specialty like emergency medicine or surgery. So that's why the government thinks they need to produce more doctors to cover all area or all fields. So this shows the number of doctors per population increasing, or also the dentist or the pharmacist. So maternal and child health law in Japan said a woman should report to the mayor when she is pregnant, and local government shall issue a maternal and child health handbook upon the notification of the pregnancy. And the pregnant women should record when she has antenatal care, and an ordinance of the Ministry of Health decide the format of an MCH handbook. So when a woman knows her pregnant using the urine test by herself, now it's easy for them to do that. They go to the clinic or hospital, have a examination by a doctor. So doctor issues pregnant certificate. So then woman go to public health center to submit the pregnant certificate. Then local government, public health provide MCH handbook to women. So when pregnant woman visit clinic or hospital for NC, antenatal care, a doctor or midwife records what they did or the result of the examination on MCH handbook, and also for their patients record. Yes, this is the inside of the MCH handbook. So the contents, the basic contents are decided by the government, Ministry of Health. But the local government make, not the central government provide. The local government have to prepare or the print out, make this handbook for their citizens by themselves. So this is another page. So here, so when we open the book, we can see this page, and this page is used for birth certificate. So this notebook is not only a record or MC visit, but also the record of birth certificate. This is the mothers have to write the information in the notebook by themselves. So MCH services are not only clinical, like only health services, but also it should include like administrative services, because pregnancy and newborn baby are new, because we will have new person by pregnancy and delivery. So we will have one more person in the population of the country. So it should be registered. So at hospital clinic, so they provide antenatal care or delivery care or the postnatal care. But also local government should know their pregnancy. So that should be registered. And the Ministry MCH handbook is issued to women. And so mothers and parents class are provided or birth registration should be at the local government. And after childbirth, so local government provide vaccination or health checkup for babies to monitor babies' health and condition. So this graph was made by my student. So as a handbook distributed, so like a MMR and infant mortality ratio increased. So what kind of examination are provided for Japanese pregnant women? So at every time, body weight, blood pressure, urine, and sugar and protein are measured, and doctor perform ultrasound at every time. When I was young doctor, only 3 or 4 times during pregnancy. But now, we must provide ultrasound at any time. The patient expect, and then also like a health service is a service, so patient is a customer. So most top hospitals and clinics now that ultrasound is a kind of service. So pregnant women want to see babies, and then they request to show face, but they want to know gender. So like doctors provide our service, so we should be kind. So I also try to use like a 4-dimensional ultrasound machine and try to show face to make patient be satisfied. If they can see the baby's face by ultrasound, they are so happy. And we don't charge extra money, but it is a way to get more patients. So, sorry, could you go back? Yes. So other than the ultrasound and blood examination and cervical cancer checking should be performed in the beginning of the pregnancy. And we provide these infectious diseases examination, hepatitis B, C, HIV, so human T-cell leukemia virus. This is common in the south part of Japan, and it will cause leukemia later. And syphilis, rubella, chlamydia, and group B streptococcus. In Japan, health insurance coverage is almost 100%, but Japanese health insurance can cover only diseases. So what are diseases? Pregnancy is not disease, or delivery is not disease, or contraception is not for diseases. So these are not covered by health insurance. So patients have to pay 100% fee for antenatal care and delivery. But if so, the fee is very expensive. So how we manage? So first, local government provide free coupon for NCD. So it's so at least 14 coupons. So when I visited to check out the public health center, I asked the average of NC visits, and they said about 6. But in Japan, like 10 or more. So pregnant women visit so often. So 14 coupons are needed. So the average cost, I think, this is Indonesian rupee, I calculated. So that may be enough. So Japanese, this free coupon has a power of implementation. I showed the examination during pregnancy. So the coupon says, the coupon can be changed to the money or income of the hospital if all services on this coupon is provided to patient. So next, Okay, so each coupon of like a first visit, second visit, third visit includes these contents in a coupon. If all examinations are done, this coupon can be money. So the coupon is not only free coupon for patient, but also it has a power to implement, to provide all services necessary for pregnant women for their health. So this is a good point, I think, this free coupon. So, and also free dental checkup are also provided. So next. So the other law I like to introduce, a woman can have a maternity leave. So maternity leave is decided by the government, especially after delivery. So 8 weeks of maternity leave should be provided for mother's health. And employer shall not assign expected or nursing mothers to work injurious up to pregnancy, childbirth nursing, and that like. So if woman or worker who is pregnant is working in hard condition, they can claim the employer to change her job, or they can ask doctor to write a letter to change their work environment safer for them. So another financial support is long-term birth allowance service. So delivery is not covered by health insurance. It's so expensive. But health insurer means a company or employer's company or local government pays almost the same amount of the fee for delivery. So it is also very helpful. And if a pregnant woman has a twin baby, the allowance is double. What if a triplet, like 3 times. So there are like law regulations and supporting service for pregnant and delivery. But still we have like 20 or 30 mother's deaths, even though maternal mortality is low, but not zero. So OB/GYN doctors in Japan want to reduce to zero. So biologically it's impossible, but I'll try. But how? So first, we need to analyze the data. We need to know cause of death. So this is the data of 216 deaths in Japan. So the first major cause is bleeding, and brain bleeding or brain infarction, and amniotic fluid embolism or the cardiovascular disease, lung disease infection. So we have to know the data. Data is very important to improve the situation. So another survey, so analysis of 477 maternal deaths in these 10 years shows here you understand. So almost all reports can be analyzed. So we have a reporting system or the registration system of every maternal death. So because we need to analyze. So then the result shows, so MMR is increasing by parities. If a woman have more children, MMR is higher. And also, zero is also a little bit high. So next. And also, fertility rate is related to maternal mortality ratio. So this is also the result of the analysis of the maternal death. And so this is the age. So according to the age, like older age, the age is older, MMR is higher. So why? You must know why like elder or older mother have higher mortality or more complications. yes, next. So in Japan, and also we have aging society in the population. But also we have like a mother's age also getting older. The marriage age is older, and having the children's age is older. So if mother is older, like an incidence of the baby's anomaly is increased. Next. And perinatal mortality rate, like a stillbirth and neonatal is also increased. Next. And also cesarean section causes maternal death. High. Next. So this shows the Japanese data. Sorry, so this is Japanese. But here, now the average is about 25%. So how much do you know the average cesarean section rate in Indonesia? When I visited the big hospital, they said 80. So it may be, it must be because of general hospital. But cesarean section also causes trouble for next pregnancy. So you know cerebral palsy, so that the baby's bad condition after delivery. So if it happens, it's a big burden for parents and also family, all family, not only for the financial burden, but also their physical and mental burden. So, and also it causes lawsuit. If baby's condition is not good, parent thinks doctors or hospital must be worse, provide health services not properly. So to avoid such situation, so Japan started the system of the compensation system for cerebral palsy. So the system is but yes, so every pregnant woman needs to pay some money to the hospital. The hospital, the clinic, collect the money from each pregnant woman, and that money is saved in the organization. So also they collect the data. So next. So first payment per baby was 30,000 yen. But after now it was reduced after knowing how much is needed to keep this system. So the criteria for compensation is also decided, because if a baby is premature, like 24 weeks or 26 weeks, the percentage of baby's program is higher, like similar to cerebral palsy. So if the baby was born after 20 weeks or some certain body weight, about this weight, they can claim about this baby. Our baby must have cerebral palsy. So, okay, so if I have a baby with not preterm delivery, but I thought my baby may have cerebral palsy, I can claim to the organization. And if the organization accepts my request, they will pay a big money to me or my family. But also they collect the data. So they accumulated the data of babies who have cerebral palsy, and also they collect the healthy babies' data and analyze and compare, like a case control cohort study they conducted. So this is one of the aims of this system, not only providing compensation, but also knowing how we can prevent cerebral palsy. Because sometimes without no reason, without any reason, we have cerebral palsy. So the result shows placenta abruption, so placenta suddenly removed before delivery, or during rupture, and acute delivery due to emergency status of baby. So this, you can see the alteration, risk ratio is high. So if we know, so these may cause cerebral palsy higher, we can prevent, we can prepare. So next. So this is a placenta abruption. So suddenly placenta is removed. So the baby may die or in a condition of low oxygen. So another topic about related to maternal health is postpartum depression. So after delivery, mother has in a new condition. So many women are in like a blue, we call maternity blue. So maternity blue will be recovered mostly, but some women have depression actually. So why postpartum depression is important? It's because related to suicide. So usually maternal mortality ratio, this is used as one of health indicator. It includes deaths during pregnancy and within 42 days after delivery. But if we see the women's deaths who have childbirth in the past year, the situation was different. So in the UK, 25% of maternal deaths within 1 year after childbirth was psychiatric disorder and suicide. And in Japan, one study was conducted in 2016, so using the data in 2014. So MMR in Japan is very low, but if we include women of like 1 year after childbirth, the MMR was like higher than normal MMR, like 3 times higher. So it was big news for OB/GYN doctors. So before we didn't know this postpartum depression, but after this survey, we knew PPD is important issue for mother. Next. So this is the cause of death. Within 42 days, within 1 year. So you can see the difference. So within 42 days, bleeding is a major cause. Here, you can see 12.29 is suicide. But within 1 year, the major cause is suicide, 28.6. So we can understand seeing the data. So this is the conclusion of the strategy to improve maternal health in Japan. So first, the regulation of professional, midwives, and community nurses, not traditional birth attendants. That is regulated by the law and also implemented. And the regulation of places and methods for pregnant women to get correct information. So maternal and child health handbook and public health center was built, and the health guidance is provided from the public health nurses. So financial support is necessary, like a coupon for ANC or lump sum birth allowance system by health insurance. And also law are very important. After the World War II in Japan, so maternal and child health law was established with the community health midwife, hospital nurse law, or the health center law established. So other problem is now the perinatal depression and postpartum depression of mothers aging. So after we knew postpartum depression is one of big issue related to mother's health and death, we increased the number of PNC. So before 1 time at 4 weeks, but now 2 times, 2 weeks and 4 weeks. And during PNC pregnant and during PNC, we use screening tool for postpartum depression. If we suspect this patient may have depression, so we contact the regional public health center, then ask the public health nurse and office to visit the patient home for the contact and support continuously. So this is one of the strategy and intervention to prevent mother's death by postpartum depression. But this is not enough because mothers visit OB/GYN clinic until 4 weeks later after delivery. So after that, they visit pediatric clinic for immunization or for babies. But nurses or pediatricians of the clinic are not interested in mother's condition. So the care for depressed mother is not continuous. So I think it should be solved, not only in Japan but everywhere. So I'd like to share some of my studies related to maternal and child health in Asian countries. First, as I explained, like a postpartum depression. So in Japan, still we need more psychiatric doctors or counselors. The number is not enough. So when I asked the professor of psychiatric department of Nagoya University about the study in Asian countries, so he was angry because still in Japan we are not having enough system for postpartum depression. So why you conduct study in Asian countries? But I did because I know, like now, I had a PhD student from Laos. I heard from her that there is only 1 or 0 psychiatric specialist in Laos. But I thought we are all the same human, so maybe the same condition happens. So people don't know about postpartum depression in Laos, but I thought that there must be some women who are suffering from depression after delivery. So first I conducted this study at Central Hospital, who visited PNC service at 6 or 8 weeks after delivery. So after that, I also conducted health centers in Cambodia or tertiary hospital in Myanmar. Next. So I collect the data, social demographic information, obstetrics and infant information, or the women's partner, because partner is very important for developing or preventing postpartum depression or marital relationship satisfaction or family support, child-rearing information, history of depression of the woman and partner. History of depression is one of the big risk factors. And I use the Edinburgh postnatal depression scale for identify suspected DPD. So this is the Edinburgh postnatal depression scale. So this is used widely in Japan, in the world. So Japan also we use this in during pregnancy in ANC and PNC. Next. So these are summary of the results in 3 countries. The prevalence was high, 30%. So the worldwide, it said the average is 10 to 15. So compared to the worldwide average, it was higher. And the risk factors is unintended pregnancy, unwanted pregnancy, or depression during pregnancy or before pregnancy, history of depression, or unsatisfaction with husband relationship, or mothers, the support from partners, parents, or parents-in-law. Also having more ANC is important to prevent, or income dissatisfaction, not low income. The feeling not enough about income is important. So this is the result of postpartum. So the next is infant mortality in Laos. We used the national data, like mixed data. So we included the women who had childbirth in the past 2 years, and then next. So this shows the maternal infant mortality ratio and neonatal mortality ratio. So you can see it decreases, but here not stable. So why it is stable, not continuously decreasing? So next, the next. So we analyze the data and what are factors associated with infant mortality. But so pregnant at the time of interview, it means like a short interval of pregnancy and low number of MC visits or having anemia. Next, or birth attendance of auxiliary nurse, like a lower educated nurse, or male, the boy, are more likely to die, or no postnatal care. The next. So these are I conducted, and I conducted a study on menstrual hygiene management among high school students in Laos. So because I had Lao student as a PhD student, I worked with her a lot. But I also conducted a study with Indonesian students about cervical cancer, breast cancer check-in at the public health center in Jakarta. Or the last year's student was from National Health. So she brought the data of national survey on satisfaction with public health center. So now we are submitting the journal. So these are all my presentations. So thank you very much for your listening.
Okay, thank you, Yamamoto Sensei. So once again, let's give a big applause to Thank you for the great presentation. So we conclude here that Japan has already significantly decreased for the maternal mortality ratio, and we also found that some major factors related with the decrease of the ratio. For the first is about the midwife trainings, and also the financial support, as well as one of the interesting things here for me, I think the allowance. Yeah, I think like the coupons, because in the context of Indonesia, some of the health finance about the delivery are supported by the government, but in Japan there is no support from the government. Okay, that's one different things. Okay, now we would like to open for the Q&A sessions. So I invite for 3 questions for the first. Okay, the one first, 1, 2, and 3. Okay, let's start with this.
Okay, thank you so much for the chance. My name is Triana from Stikas SDM 9 Udayana. Thank you, Prof. Yamamoto, for your great presentation. I want to ask 2 questions for you. The first thing is I interest to your statement about the regulation in Japan, about that Japan has a regulation. I just want to know about the consideration why for the dental consultation is provided for free after birth, and maybe, if I'm not wrong, 2 months after birth. Yeah. And then the second one is, how about the regulation of mola hidatidosa? In Indonesia, we call it hamil anggur. Because I have a friend 2 times for mola hidatidosa in Indonesia, and 2 times of operation. Is it possible to provide in your country, in Japan? Thank you so much.
Thank you very much for your question. The first question is about dental check.
Yes.
Yes. So during pregnancy, so they can have 2 times, and also after delivery. So it's because during pregnancy, so that MSS, morning sickness they have, so their oral care may not be enough, and then also they worry about treatment by a dentist is dangerous for them. So, but oral care is related to every disease. Also, there is some research that suggests bad oral environment may cause preterm delivery. So oral environment is very important for not only for pregnant women, but if we provide coupon, they want to use. They know if it's free, they want to get. So that's why free coupon includes dental care. And the second question is about treatment for heredity for more. So you need 2 times operation for 1 molar disease.
No, I mean, the first pregnancy is detected of molar in the second semester, and then the second one is first semester.
So
Yeah, so 2 times of molar hip.
sometimes, it's very rare, but we have like 1% of heredity for more of the patient have the second one. So it shouldn't be continuously, but like a heredity for more and normal delivery, then they may have some like a heredity for more again. I have 2 patients who had 2 times. So it happens, but in the world, it is reported that there are some families of like repeating heredity for more because of the genetic disorder, but it is not in Asia. It's very small, like a very special families. So usually we don't need to worry. If you see the patient who had second heredity for more, you can say it's very rare. You don't need to worry about. So the third pregnancy will be okay. So yes. So this is my
Thank you
question.
so much for the answer.
Okay, thank you, Yamamoto Sensei. Second questions? Okay, I think in the middle.
Okay, good afternoon, Prof. Yamamoto. Let me introduce myself. My name is Anna from Moderator student in third semester. I will ask you about 2 questions, and I'm interested with postpartum depression topics. And first, what causes postpartum mother in Japan suffer depression? Is that determined by a husband's support, or there's other causes? And second, what action our government of Japan already do or will do to prevent mother death caused by postpartum depression? Thank you.
Thank you for your question. The first, the causes of the depression, postpartum depression in mother are the same as other country. I think if mother feels some stress or so dissatisfaction, if they develop postpartum depression. So mainly the relationship with partner. So and the others is like a history of depression or other psychiatric diseases. So to prevent postpartum depression in Japan, as I explained to you, so first screening during pregnancy. If we know earlier high-risk woman, we can do some intervention. Like we can support them. We can listen. What are problems? The relationship with husband, with relationship with family, or financial difficulties. So first screening and find out the reason and problems. And if we can solve the problem with them and with their families, we should do. But we should know earlier than after development. So screening in pregnancy, during pregnancy is important. And also the government started the program to provide more support. Is like a local government provide like facilities for short stay for postpartum women, because some women need support different from in Indonesia. I think in Japan we have more nuclear families. So families are living by themselves without support from parents or from relatives. So if so, like only mother or the father are not enough. So mother needs support, but the father must work at the company. So no time to work, or like Japanese men are not so kind to be like doing housework. So if so, they can ask the local government or the use the service to stay for a week, it's kind of hospitalization to be relaxed. And also the nurses or the midwives can teach how mother should do when her baby is crying, if she has some problem with breastfeeding. So such education or guidance by healthcare workers or caregivers are good support for them to prevent depression. So but these are started intervention to prevent postpartum depression in Japan.
Thank you, Yamamoto Sensei. Another questions? Yes.
Okay, good morning, Prof. First of all, thank you for your presentation. My name is Vincent, third semester student from Public Health. I have two questions. Maybe first, same like Anna's questions. I'm interested because the decline in the grade of maternal and child health case in Japan is very good. I want to know how the role of a husband in Japan is during his wife's pregnancy and postpartum period, and how gender equality is implemented there. Of course, not all of this is from the medical aspect, but also from the social aspect. So I want to know that. And my second question, I also want to know how the company in Japan, where the pregnant woman works, can support the mother's pregnancy and birth. Thank you.
Thank you for your question. The first question is about the role of fathers. It's difficult because Japanese men are not so different from European men, not one for housework, one for babies. But the younger generation is changing. They use more time for their family or for wives. So now, Japanese government push women and the men to have paternity leave. But it's a very, very small number, but increasing. So also the company or the employees should encourage men to have paternity leave. But it's also difficult because the generation of their boss is not like that. So they think if a male worker requests to have maternity leave, why? So you should be moved to the other section that is not so busy like that. So we need time to change the society to accept for promoting the paternity leave more. But that gradually changed. So the Japanese government changed the law related to leaves for delivery. But paternity leave is now officially introduced. So if a male worker requests, the company must not say no because of the law. So in Japan, the law is implemented very strongly. So if we say, we have this law, so that's why we request this. If so, nobody can say no. So making law is the first step to change the society. But still, we need time to change, to promote the father's role for involvement in the childbirth. But the fathers or the husband are with wives when the delivery. It is encouraged. So the second question is about a company. So work environment, that is also decided by the law. So if the worker, the pregnant woman, if request to have to make shorter working hours or for breastfeeding, they also can get because of the law. So actually, our department will have a new lecturer from next Monday. So we decided taking her as a new professor to our department. She told me that she's pregnant. So she will have maternity leave. It's a right for her. Also, she can have childbearing leave. So at least 3 years. But she will have her maternity leave will start 2 months later. So I'm a boss for her. But because of the law and regulation, I cannot say no. You are new worker. You cannot take maternity leave. I cannot say. I should encourage her to take leave. Also, I'm feeling something in my mind. But I'm expecting her to work for us hard after child care leave. So we must be a senior position to understand the law. Because if the work environment is not good for both women and men, our productivity will not be increased. So if so, women will stop work. Now, gender gap in Japan is very big. So the problem is the work environment is not kind to women. So if so, they will stop, they will quit and be a housewife. So that is not good for Japanese society. So the law is very powerful in Japan. So we can change implementing the law. So that now all women who are pregnant or after delivery can have leaves or can work in a safe environment. Okay, thank you very much.
Thank you. Yamamoto-sensei, maybe one more question. Okay, over here.
Thank you, Yamamoto Sensei. My name is Bintang. I'm from undergraduate public health 5th semester. So I was interested in the law. So I remember correctly, it was said that all pregnant women should report to the government. But what if, or maybe there has been a case where the woman didn't want to report? Is there anything the government could do for that?
Thank you. Interesting question. We cannot do. If a woman doesn't report, we cannot. So sometimes we have emergency patient who is pregnant. Somebody come to emergency room and delivery. It happens. So we cannot do anything. We cannot force them to come. So that is another problem. Like especially young women who are not married. I had once a homeless patient. So also after cesarean section, she disappeared. She left a baby. So that also happened in Japan.
Okay, thank you, Yamamoto Sensei. Maybe one follow-up question for me and from me about, like you mentioned, people that when the law is so powerful and also the government support, the financial support is already so good. So is that also applied for the migrant worker or only for the Japanese?
So even tourists are not covered by health insurance, but if they register as a residents at the local government, they must have health insurance. So the bus allowance is provided by the health insurance. So and also like a coupon is provided by the registered local government. So even if they are like a Chinese, Indonesian, Korean, if they are registered citizens in Japan, they can receive any benefit the same as Japanese. Really.
Thank you. So, as we have limited time, maybe we should end the sessions and discussions. And if you have any questions after the sessions, maybe you can send them to the committee and also to me, and then we would like to send to Yamamoto Sensei. Okay, now let's give one more big applause to Yamamoto Sensei for your presentations. Now I would like to offer to the Master of Ceremony.
Okay, ladies and gentlemen, let's conclude our international guest lecture. And on behalf of our organizing committee, I would like to extend our heartfelt gratitude to our distinguished speaker, Professor Eiko Yamamoto, for sharing valuable insight, and our moderator, Ngakan Putu Anom Harjana, for facilitating the session. And before we officially close today's event, there will be a token of appreciation present. And now we invite Professor Eiko Yamamoto and our Vice Dean of the Faculty of Medicine, Professor Adi Wirawan, to the stage. Thank you for Professor Eiko Yamamoto and Professor Adi Wirawan. You may now return to your seat. Afterward, participant certificates will be distributed, where you will receive a link at the end of the session. And please access the link, complete the required information, and the certificate will be sent directly to your email. Okay, before we officially close today's event, let us have a documentation session. So, for ladies and gentlemen, please be standing up. Thank you for all your participation and for your attendance. We apologize for any unintended shortcomings during today's event. Thank you once again for joining us and see you at our next academic session. Om Santi 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 Om. Wassalamualaikum warahmatullahi wabarakatuh. Shalom Namo Buddhaya. Salam sejahtera.
Agak kurang sama
Thank you.